having got through that, we're now going to hear from Gabrielle, and she will tell us where the Commission's going, what we've done up until now, and what the plans are, particularly in relation to these areas for the next year.
Thank you very much. Okay, so I've got the challenging task of being the last presentation for the day, and all of the tricks I was going to pull out of my sleeve have already been played by my colleagues, so I haven't got anything that's too startling, but I'm hopeful that you're interested to know what the plan is for the coming year, and hopefully for the majority of you this isn't startlingly new news. But first of all, a little bit about where we get our information from, just a bit of a refresher. So we look to the serious adverse event reporting. We talk to our ACC colleagues about their treatment injury data. Of course, there's the Health and Disability Commissioner. And we interrogate the national minimum data set. We also compare against OECD data to see how New Zealand stacks up. Hopefully you've seen this before. It's a great sort of summary of the case for change. Why is it important that we're doing this work? There's some pretty startling statistics in there. I've never used a pointer before. Let me go. So look at that one. Foreign bodies left in the procedure, our rate versus the OECD average. Accidental puncture or laceration, our rate versus the OECD average. Another thing that we look to is serious adverse events, as I mentioned before, and this is quite telling, really. I mean, look at, it's not going to work now. I broke it. Here we go. Retained item swab, the big blue sections here, and then wrong site. Bits there. I pulled out some of the details. Apologies for the brevity of the far right column. Sometimes that is all the information that we get if people don't complete the fuller sections. And that is just some of the SAEs. I only wanted it on one slide, so I've actually left them off. And it just makes for sort of quite sobering reading. One thing that is really good to see on there is the near miss. So no harm, but definitely it's wonderful to see that that's being reported in, because we can learn from that. And imagine the potential harm if it hadn't been spotted. So what can we do to stop some of these things from happening? That's what we've been talking about today. We want to move into a more open culture, a more improved teamwork, improved communication, working together to solve these issues. We've got the interventions, briefing, all three parts of the WHO surgical safety checklist, and debriefing, and they are really about improving teamwork and communication. I want to encourage people to continue to report in so that we can learn from people, the mistakes, and hopefully make sure they never happen again. But most importantly, tell stories, share learnings across the sector. One of the things that I would really like to see happen over the course of the next year is we get case studies about all the good work that you guys are doing, and get them up on our website, get them presented at the right forums like the Perioperative Nurses Conference. Have you guys standing up on the podium telling your stories to your peers rather than hearing them from us. So there's lots of evidence to support appropriate use of the checklist. The most recent one here was only released just recently. The first ever randomised control trial of the checklist found a decrease in complication rates. We've got a really good summary of all the evidence that we've used to sort of develop our program up on our website. So I'm not going to talk through all the detail here. You can go on the website and find it. And if you have any problems with finding it, let me know and I'll email it to you. Briefing and debriefing, Ian's already talked about evidence, but there is a lot of it out there. We're not just making these things up. Just a quick word about the quality and safety marker. I think that amazing achievements have been made, but we recognise that we perhaps haven't driven quite the right behaviour. The current checklist being that current QSM being that all three parts of the surgical safety checklist are used in operations has perhaps driven that somebody stands there, goes tick, 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 sign, it goes into patient notes, it's a compliance, it's audit, and it's not really improving teamwork and communication. So As a result of that, we're retiring it. Hopefully you've all heard, no more reporting on that QSM. And we're going to have a year's hiatus on any kind of public reporting while we roll out the new way of working, which is a move to a paperless checklist, help you guys get it in place, and then we'll have to start the public reporting again. Can't do away with public reporting entirely. I know some of you would love that to happen, but we're doing our best to give you a decent break and get you set up in the new way before a new one comes in. In 2012, we did, as a sort of precursor to this work, we did a survey of people's attitudes to the checklist. I'm hopeful that some of these attitudes have shifted, but I think it's still relevant to put it up here that perhaps there could still be a lack of understanding of the overall intent and applicability. Lack of understanding that they are teamwork and communication tools. They're not audit and compliance tools, even though we've perhaps contributed to that thinking. We ran a proof of concept project last year. Hopefully you've all heard the final report from that went up on our website in December, with Waikato and Lakes District Health Boards and Auckland Central Southern Cross Private Surgical Hospital. And they have helped us to figure out ways to roll out the program to the wider sector. They taught us what was necessary. One of the first things they said was, please give them enough time. The proof of concept, we perhaps didn't give them enough time around in the preparation phase, and they went too quickly from preparation to implementation. So in a future slide, I've got the timelines up, and you'll see we've allowed a lot longer for preparation. Another one, really essential, clinical leadership. Making sure that you've got senior levels bought into supporting the project, and if you've got a recalcitrant surgeon or you've got somebody who just refuses to play ball, you can get some senior involvement and help with that. The peer-to-peer support. So I'm sure you're familiar with the collaborative methodology. We're trying to borrow bits of that methodology for this piece of work, and one of them is about doing learning sessions, bringing everybody together to have learning sessions and share between teams what's working and what's not. What the proof of concept taught us was that the tools do work, and they can be used to improve teamwork and communication. And also, it wasn't an aim, but a happy benefit is that they improve efficiency. And Lakes has even reported that they've been able to add in extra procedures onto their list. So plans for the next financial year and beyond. No QSM, as I've already mentioned. A phased rollout of briefing and debriefing and move to the paperless approach. We've gone out and contacted all of our champions at DHBs and spoken to you guys about what cohorts you want to be in, make sure we've got the right contact information. Cohort 1 is pretty much confirmed. I can't see that one changing. Cohort 2 and 3, there is still a little bit of shifting going on as DHBs decide actually they want to be with their peers or with their regions. Each DHB will receive targeted training in how to implement the changes, and that'll be training in both the sort of ideal scenario of what does an ideal day in the theatre look like with your briefing, your paperless checklist and your debriefing, but also training in the communication tools that Miranda presented in her presentation, ISBA, 2-challenge rule, closed loop feedback and call-outs, because we don't expect you to be able to implement those without having some knowledge of what they are and how best to roll them out. We are going to have a new QSM, as I've mentioned, so we are also factoring in training for each DHB to nominate a person or a couple of people to get train the trainer training, so that they can then go back and bring colleagues up to speed around observational audits, because the data we're wanting to collect from 16-17 is the levels of teamwork and communication, and it'll be about somebody coming in and observing the all 3 parts of the checklist actually being done and grading that on a scale. So we need to give training first of all in the logistics of that. We've developed an app so you can do real-time data entry, and you can also look at your data for yourself whenever you want to, see how you're going and compare yourself to other DHBs. You'll be able to see your data and other DHBs' data will be anonymised, but also to make sure that everybody's across the country is rating the same. We can't have one person who's a generous rater, giving everybody 7 out of 7, and another person down the road for exactly the same level, giving them 5. So we'll make sure that we get a standardisation across that. And this is the summary of the timeline. So cohort 1, kick-off 1 July, which is scarily close. You can see that we've planned a learning session, bringing the cohort together in August. We've planned the intervention training around the communication tools for September, and we've planned the auditor training for November, and we will be doing a lot of communication in the build-up to this. So my presentation tomorrow up in Auckland, everybody should be nodding. I hope they will have all heard about all of this. Cohorts 2 and 3 slightly behind, and we've treated December and January as dead months, which is why you've got the slightly extended preparation times there. I know work does carry on, but if we don't do that, we always end up in trouble, so we've done that this time round. We will also be running webinars, voluntary webinars for people to dial in and talk to one another. We'll also be doing newsletters, putting information up on the website. There are lots and lots of ways that we want to communicate with you and make sure that you get all the support that you need. And this is the penultimate draft of our briefing guideline. It's still getting a few minor tweaks. One of them is the colour, because nobody likes it. So you will be all sent these resources to use. What we'll probably do, again, I'm saying probably because we're still finalising these details, slightly late in the piece, but we will be sending everybody copies of a how-to guide, quite a comprehensive one for you to have to refer to whenever you need to. And we'll also send a set of our resources, and you can then order as many as you like. These are not compulsory. I'll flick on to the next one. That's the checklist. They're not compulsory. They are for you to choose to use if you want to. We'll also make available on our website the Southern Cross version of the checklist. They've put a lot of time and money into developing a version that I've seen a draft of. It's looking really good. And ADHB have also created some really good posters. They actually put the 3 sections on 3 separate posters. Put that up on our website. Equally, you can design your own, meant to be guides rather than the compulsory version. And as many as you need printed, we will print for you, so you can have them up on all of your theatre walls. And there's the debriefing version. And of course, if you've got a poster that you know matches kind of the gold standard, there's nothing missing, and you want it up on our website, and you want other people to be able to use it if they want to, please do let us know, because we would love that. So options, not yet, but they will be. We've got verbal permission, we're just waiting for the written permission, and then we'll put them up. Yeah. So options for support. In addition to all the planned stuff that we've got, you can also get our clinical leads to come and visit. They could come and speak at a grand round, or if you want it to be more personal, get a team together and have a working session with them. We can arrange that. We've got quality improvement advisors at the Commission. You can get access to them. They can help you, especially once you're collecting the data, they can help you to understand the ways to use the data and turn it into meaningful quality improvement data. Lots of resources on the website, as I've already said. We'd love it if DHBs made connections with one another. So if you've had a success, we'd love to hear about it, so that if somebody else is struggling with the same thing, we can put people in touch. The other thing is that you can always contact me. I have an open inbox policy of my mobile numbers there. Feel free to give me a call. And the only thing I have forgotten to mention is that we do want to include private hospitals in this. So we are hopeful that private hospitals will be invited by their neighbouring DHBs to attend the learning sessions. We're going to do as much as we can to make sure that that happens. And we're providing them with the resources as well. We're working through the Private Surgical Hospitals Association and Southern Cross to make this all happen. So, we'd really like to take the whole sector on the journey. Another piece that I've forgotten to mention, I did this yesterday and it came off my tongue perfectly, but today I've forgotten 2 crucial things. Hopefully you have heard we're doing a culture survey. We've got Harvard's permission to modify their safety culture survey, and we're doing that over the next month or so. We've contracted that out to a surveying company, a specialist surveying company. And they'll be in touch with you about how to disseminate it within your organisations. That's about establishing a baseline, and we want to repeat the survey in future years so that we know how things have changed and where we've still got work to do. So, any questions?
Are you retiring the Pure Samples at the moment? Are they finished already? Or?
There's one more publication coming out, so you should have already submitted for the one that's due out in the next couple of weeks, and after that, no more. Yeah. We had a really good question yesterday that I might just mention today, because you might go away and think of it. Somebody said, well, the question was regarding getting rid of the paper version, because what if that's been built into kind of standards, or sort of that's moved into more being of a regulatory kind of, you have to be able to demonstrate written proof that you've completed the checklist. As far as I'm aware, there's no standards or requirement set that says you have to have the full checklist, tick, 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 sign. Some hospitals have incorporated that into their internal audit process, so those hospitals will need to work it through, but we've certainly got no requirement that you keep doing the paper one. If you wanted to have a written statement to say that the checklist was completed, you could add one checkbox, for an example, into patient notes. Was the checklist completed? Tick. That would probably suffice, but certainly from our end and the Ministry of Health's end, there's no requirement for you to be able to produce pieces of paper.
So how will the monitoring happen? Again, like kind of jumping the gun a little bit around the information around compliance when it comes to 16, 17.
So we've developed an app as part of the proof of concept project, but equally you can set up your own method for collecting the data and storing it. So our plan is that we'll have trained observers popping in and out. We don't need them to stay for the entire operation. They could come in time to see the sign in. They'd probably stay to see the time out, because usually they're relatively close. But they could go away and come back again, and maybe it's a completely different operation, but they arrive in time to see the sign out. There'll be a requirement for a certain level of sign-ins, time-outs and sign-outs for them to get us to a statistical level. And as that data is entered into the app, it gets recorded in a database, and quarterly we'll extract from that database, and it'll be just like the reporting that's been done for the current. It'll be that, I had a slide. Yes, similar, except it's not about completion, it's about did the team engage. Yeah. Yeah, sure, it is very like the hand hygiene. We've plagiarised that completely, yeah.
Do you guys, as a team, talk to surgeons about this? Because I find the debriefings and checklists and things, the ones that work the best are the ones with the surgeons.
Oh, absolutely. So the answer is yes. Ian has been travelling around the country, going to grand rounds, talking to surgeons, talking to surgical groups. He can probably come up and speak more about that, but I don't think we can ever do enough. We will keep doing it. We have an advisory group that's got a blend. It's got quite a few surgeons on it that in turn are supposed to go back and talk to their colleagues. And yeah, did you want to add to that?
Just as far as the paperless checklist is concerned, they will need to be engaged, if you like, if they like it or not, because it will be the standard. And just as now, I'm sorry, you can't progress, we've got to do the timeout, there's your job, that'll have to happen. And there'll be some who will embrace it. Most, in fact, like 95% of people that in Auckland who have actually state they love it, because they suddenly love being in charge. I always love being in charge. And they love being given charge of this bit, and then they can takes exactly as long as they say. They just work through it. There's a tiny group of people who feel one of the it interrupts my concentration as I'm planning for the operation. But that's one of the answers. So the answer to that is that's fine. It's okay for you to delegate it to a member of the surgical team, so you can delegate it to your registrar. Very useful learning experience. They can run it, but it has to be run by the surgeon. So no problem with ultimately engaging the surgeons. Briefings is more complex thing, and I don't propose sort of mandating it and saying that, well, this won't start with a briefing. It's a matter of just gradually working through, because everyone that does it is ultimately a champion for it, because they all like it and they all are complete enthusiasts for the fact that this is great. I just turned up for 5 minutes, did a briefing, and the whole day was fantastic. And they asked all the questions, everyone knew what was going on. The anaesthetist, I knew what was going on. I knew that the anaesthetist was going to take a long time to anaesthetise that second case, and so that meant that's when I immediately knew I didn't have to go and do a ward round now, because, well, I could go and do it after this first case. I'd have a whole hour by the time we've done his epidural and nasal intubation and God knows what else, all of those things. Everyone, so I don't have an upfront answer for the briefings. I think that will be an iterative process, and we'll just have to work through the individual surgeons in each hospital that embrace it, and ultimately keep going and talk to their colleagues about the experiences that they have.
And I'll let you into a little trick which I haven't explicitly said. You could have got it if you read between the lines. In 1718, when we start reporting, we're reporting on levels of teamwork and communication with all three parts of the checklist. So you'll have a whole nother year to keep working on getting briefing and debriefing into place before we want to start collecting information about that. So we recognise that those two parts, the bookends, are the more difficult parts. Emma.
I just wanted to clarify with you, when you roll out this paperless checklist, that the anaesthetist is leading sign in, the surgeon leads time out, and the nurse leads sign out. That will be the driven standard.
That's the ideal. And we're going to say that that's the ideal in our how-to guide. We won't put that on the posters. That's the ideal. Yeah, that's how it's been proven to work best internationally. Any other questions?
So the private hospitals, for the cohorts, that's DHBs there that get,
So, yeah, what we would like to happen is that because a lot of the surgeons and the anaesthetists are the same. In private hospitals, the nursing staff is often purely private, but the others it crosses over. So we would like for the private hospitals to join in on the DHB learning sessions, because it'll be the people they're working with. Yeah, but we can't force that. We can't force the private hospitals to go, and we also can't force the DHBs to invite them. We just have to ask and give as much encouragement as we can about that. That's what we would like to happen. Yep.
What do you recommend for, in the second cohort looking ahead, doing at the moment in terms of, just drumming up some enthusiasm and talking it up?
Yeah, I mean, a visit from one of the clinical leads for a grand round, or running a workshop. We get people together. If Hutt Valley does a half day's training every month, maybe it could be a topic on a similar thing. If you have that, I'm happy to come and speak. Lots of information available on our website that you could use. It's really over to you. I know that Canterbury DHB, which is in cohort 2, is just choosing to just not do a lot until they get closer to the time, because they don't want to drum up a whole heap of enthusiasm and then it sort of wanes while you wait to start. Equally, and this is what I would love to happen the most, start. Don't wait for us. If you're ready, go for it. And then when we come along, you'll be like, oh, we're sorted. No drama.
I just have one more question.
Sure.
Just in relation to within organisations, there are procedures that are done outside of the operating theatre quite frequently, actually.
Yeah.
About what is it going to look like moving forward around organisational
The spread.
processes.
Yeah. So it would be great to see that this spreads out into any area where, not the briefing, debriefing aspect, but the checklist aspect, and anywhere where any type of surgery is taking place. But for the moment, we're focused on in the theatre suites. Okay, thank you very much.